So we no more use the term dietary management. So if you want to refer your case in the future to a dietitian, use the term medical nutrition therapy. So dear dietitian, we appreciate you see this gentleman to receive your MNT. Okay? Because we are not only talking about diet, we also as a dietitian talking about the whole lifestyle management. Right? Okay, so this is what we are going to cover. What are the nutritional issues related to obesity? You know this, yeah, I'm sure. But how to diagnose obesity from nutrition perspective? And the most important part under number 3, what and how we can help them. Right? Okay. So, do you know this figure? Of course. And we still don't know. Right? And I think you are the best time, the best period of time to prevent the occurrence of chronic disease. Start with yourself. Maintain your current weight as much as you could. No matter whether you are getting married or no matter how stressed you are, how lifestyle changing over time. But most importantly, maintain your body weight. Yeah? Because we are going to see our patient, so we have to portray a good results. So start from now, yeah, maintaining your good weight no matter how challenging your lifestyle is. Because to maintain weight, what should you do? Cool, exercise. How many of you is exercising in the daily, in consistent manner? Setahun sekali?
Seminggu sekali.
Dulu ada physical exercise, sekarang dah tak ada gym kan? So, okay, so make it consistent. Consistent means, is that daily? No. Consistent means when you do that in a consistent manner as part of your daily life. So start exercising. Berapa banyak? What is the prescription for healthy individual?
30 minutes.
3 hours weekly. Wow. Yeah, betul? 150 plus 90 minutes for resistant exercise. It's no more 30 minutes 3 times a week. No more. For us to maintain our good health, at least 150 minutes. That include aerobic plus resistant. Nice. Aircon is coming in. Alright. Number 2, for the patient who wanted to lose weight, they must at least achieve 240 minutes plus 90 minutes in a week. So it's not easy, but you have to schedule them. You have to put in the schedule when we are going to. Okay, so I'm going to do the, can you go here? Boleh tak agak-agak? I pun tak tahu. Can you go to Paul E. This and Paul E. B? And we can play together. I'm not sure whether possible, but let me try. Oh, it's quite here. Boleh tak agak-agak? Macam mana cara ni? Activity status, active, invite team. I don't know. By right, it should start. Would that be possible? No. Boleh tak agak-agak? Tak boleh. Okay, this is the ball, the live ball. Ball everywhere. Boleh kan ni? I'm also trying, sorry. Okay, let me see what will happen here. Introduce yourself. Agree.
QR. Just the QR. That's the problem.
Yeah, they said I need to start the presentation. I do, but I can't connect. I'm not sure how to connect. Okay lah, tak apa. Right, so, but what do you think obesity is increasing in Malaysia? Food? What else? What kind of lifestyle? Bangun, makan, tidur. Yeah, you are right. Sleep hygiene. Yeah. Macam mana nak buat ni? Oh, resume slideshow. Can someone help me?
Exit.
Slideshow, resume slideshow. Looks like they don't want to.
Sudah.
Sensitive. Boleh. I cannot make it in the slideshow, I don't know. Okay, good. What else? 24 hours restaurant. How many of you have midnight supper? Okay. Have you know about chrono nutrition? Have you ever heard about chrono nutrition? Yeah. So where we are supposed to yeah. So in our study, for example, we found Malaysian are eating 15 hours a day. Kita tidur, we have 24 hours and 15 hours is actually spent for eating. So that could explain. And obesity is complex. So when we manage obesity, it's not only about MNT, it's not only about exercise, it's a lot of other issues.
Medical.
Okay? And this is what we can see. Yeah? So it's not like just individual activity or food consumption. It's also involved biology. What does it mean? Anyone can explain? Biology? Yang okay, that gentleman. Baju hitam. Say hi to me, okay. Right. What are the biology factors that you think predict or contribute to obesity development?
Genetic.
Genetic. Okay. Genetic explain 20% only. Okay, if you have parents who are overweight and obese, family members, you will only carry about 20%. So 80% to be blamed. So what others biology expect? Body metabolism. Have you ever heard about gut hormone? Yeah. Study have shown that for those with other chronic disease, their gut hormone are relatively low, that producing the satiety effect. And some people you see them makan banyak mana pun still kurus. Ada tak? Oh, tu yang kat tangan tolong I. Dia boleh gym. So gym something like GLP-1. Not gym. Alright? Okay, so but some people just eat just nibbling but put on weight. Have you experienced? Yeah, so because of the gut hormone, how they respond. Okay, so this is a CPG. So when you are not for your exam, but for when you are in 5th year, you will see Professor Zubaida for bariatric surgery. Then you will be needed to use this. So this is the newly launched clinical practice guideline. I have uploaded in your Putra Blast, management of obesity. But nothing that we can, for the exam, not necessary. Okay, how to diagnose obesity from the nutrition perspective. So let me introduce you with Puan Rizky.
Oh, Puan Rizky.
So
very risky.
this is one of my patients. Her name is Rizky, 35-year-old woman who is referred to us with BMI of 35. She is also present with IFG. What is IFG? Impaired fasting glucose. Is IFG already diabetes? No. Okay, no. Right? IFG, impaired fasting glucose or impaired glucose tolerant, is not yet diabetes. It is a pre-diabetes state. Okay? Right. So, is she fit to criteria for obesity? Yes.
Yes.
Yeah? Why?
Higher than 20.
Okay, for the Malaysian and based on the CPG that you are going to look when you have a time, BMI more than 27. Is she fit to the criteria of obesity because she has type 2 diabetes?
No.
Okay, no. Although type 2 diabetes and obesity is like a twin, but you not necessary to have type 2 because you are obese. We have in our population about 20% are lean but having diabetes. Yeah, type 2. So that a lot more research need to be done. Okay, so if we look at into this is how the clinician do it. Yeah. So this is the algorithm for assessment and management. Adult attending clinic, we measure weight, height, waist circumference because this is the key thing to diagnose obesity. Calculate the BMI. Any BMI more than 23, not 25. Yeah, we have to assess for any chronic disease, which I will talk a little bit later. And waist circumference. So if yes, because majority of BMI 23 is considered normal. What is the cutoff for BMI? 18.9 to 24.9. That WHO, global, normal. But in Asia, we cut down to 23. So anything more than 23 is considered at risk for chronic disease. Anything more than 27 is considered obesity from the Asian cutoff because of the increasing risk of chronic disease. So what we will do when patient present to us with BMI more than 23, assess for overweight and obesity associated condition. What is overweight and obesity associated condition? Diabetes, hypertension, risk of diabetes. Then medication. What are medication? What are the medication that can cause obesity?
Steroid.
Yes, excellent. And then patient readiness. Whether they want or not to get ready for any weight loss program, then we can offer. Yeah? Right, but unfortunately, in Malaysia, at the moment, we don't have a structured obesity program. Why? CPG put it in, but we don't have any. It depends on the individual health setting or hospital. Why? Why obesity doesn't have structured program, regimented, being subsidized? Why? Why in the Malaysian health system? Ada nama Azhar? Ada nama bapa dia Azhar? Chong? I tiba je ni. Ada tak? Devi? Tak ada. Rani Mufici? Ada, okey. Aduh, siapa yang ada ni? Husni? Hasni ya? Tak ada. Yang birthday boy lah. Why do you think so? The present for the birthday boy. Why birthday boy? Do you think so? Why we don't really have a structured program? Mana jam kedatangan? Can I have a kedatangan first? Pusing tak? Bagilah yang lepas-lepas pun boleh lah kan. I nak nama je. Sebab my poll tak boleh, so I panggil. Mana? Birthday boy? Ada jawapan? Okay, you panggil seorang?
ChatGPT.
Okay, Punita. Why do you think so?
Hah? Soalan ni kenapa kat Malaysia tak ada
Belakang
structure
dulu
obesity
lah.
program?
Betul. Oh, okay, assumption made, right?
Assumption ni.
Good, right? Any last one? Rabiatul Adawiyah? Mana Rabiatul Adawiyah? Okay. Tak tahu. Because obesity is not considered as chronic disease.
Oh.
We don't consider obesity as chronic disease as yet in Malaysia. So when they are not a disease, so they are not treated. Betul tak?
Yeah.
You can only go to health clinic if you have a disease. Betul tak? Doktor akan tanya, you all akan tanya nanti, sakit apa ni? Saya obese. Ada ubat. Yeah? Because obesity is not treated as chronic disease. That's number one. we are treating now in Malaysia complication associated with obesity. When they have diabetes, they present with obesity, we are struggling to treat both of them, diabetes. Yeah? Diabetes combined with obesity become diabetes.
Wow.
It's a term, it's a character. Yeah? So this is why we currently, I'm in the profession, working very hard to propose to the government to recognize obesity as a chronic disease. But why the government doesn't want to listen, although they know that if we treat obesity, we resolve all the problem. Why do you think so?
A lot of budget.
Yes, Menteri Keuangan kita.
Duit.
Yeah? Because of the funding. Drugs for obesity is not cheap. We are now funded a lot of drugs for the patient. Is that clear to all of you? So what we are doing right now, we are actually treating the health risks associated with obesity. So this is what I'm telling you, why 23 and above are considered, because it's increasing risk of other chronic disease that I have shown here. Yeah, one of them is diabetes. We will talk a little bit more about pre-diabetes because this is important. Okay, is he obese?
Yeah.
Why? You have learned nutritional assessment today, perhaps with Dr. Zol after this in the afternoon. My colleague, is he obese? Okay, so BMI is not a good surrogate marker because it's also, no matter what inside our body, muscle, bone and everything, they will include all together. So for those who are a bit muscular, then it may actually give a wrong interpretation to the body composition. We have to do more. You can ask Dr. Zol after this. How about this?
Yeah.
Who is he? Ni pandai lah you all. Then who is this? Okay. So this is an interesting study that was published in Lancet, yeah, from Dr. Jad Nick in, I think, in the University of Cambridge. This is where the hypothetical, when they say, okay, Asia must have low BMI, rather than following the Western counterpart. And at lower BMI, we present with many other chronic disease. That's where the history, why we set at 23. Understand? Okay, so in this study, what they do, they compare these two gentlemen. Yeah, they are about the same BMI, but as you see, they do DEXA, yeah, the machine that measures the whole body composition, especially that meant for bone. Yeah, and you can see the body fat percentage. Who actually look more bigger? The Western or the
Western.
this gentleman, right? As opposed to this professor. He is a South Asian scholar, Pakistan. Yeah. So what did you see here? More body fat.
There's no person.
No cursor. Okay. Again. Right. So this is the South Asian, and you can see the fat is significantly higher, although he look slimmer. Okay, so that's the history. And especially fat at the abdominal area. And this is mainly for men. Please take care of your waist. Right? Because abdominal fat, abdominal obesity, fat that accumulate in abdominal is actually putting us for a lot of other chronic disease. So taking care of your waist starting from now. So where are we in terms of diabetes prevalence? Are you happy with this achievement? Yes? How many of you have a family member, the first layer, the first generation with diabetes? Can you raise your hand? Tak mengaku ni satu je. Alright, so we know that 1 in 5 of Malaysian adults have type 2 diabetes, especially among your age. We do research in the UPM. We found that we also have students who have type 2 diabetes at your age. and now become our patient in the hospital. They are on insulin, they are on tablet, they are on drugs. Okay, so that's a different topic to be discussed.
Terkejut betul.
Okay, so what is pre-diabetes? As you mentioned to me just now, you are right. There are two types, IFG and IGT. So IFG is mainly at the fasting level that is impaired. If IGT is when they have normal fasting value, but they have higher glucose after meal. Alright? Okay, so when you have this kind of diseases for Puan Rizky, who is also present with impaired fasting glucose, so what is your priority? Managing the blood glucose or managing the body weight? You can only choose one because it's priority. What will be your goal?
Glucose.
Dua-dua?
Glucose.
Jian, Lim Jingwen. Where are you? Yeah. What are you hearing at? So what is my question? Why glucose? What are you reading at? Okay, glucose. Alright, Svita? Where is Svita?
Because
Svita, you will be in trouble. For those who not attended, and I see because your class rep just mentioned one MC, the rest are here. Svita? Okay, mana? Tak ada. Toilet? Okay, so bulatkan nama dia nanti untuk I. Okay. Intan? Intan, ada 3 Intan. Intan Nur. Busy? Mana boleh busy? Intan Nur Khairunisa. Kita dah doa Okay.
Saya rasa glukos.
Okay, good. Why? Good try, not good answer.
Sebab dia tak ambil makanan lagi, tapi glukos tinggi, so kita kena deal dengan glukos.
Kalau nak manage glucose, okay, your answer is glucose. Anyone agree with Intan Nur Khairunisa just now? Okay. Who say yes? Yang tengah-tengah tu siapa? The only gentleman in between ladies. Bukan?
Allah.
Brown ya? Apa nama?
Einstein.
Syazwani, what do you think? Quiet class. Why? Okay. Right. For Puan Rizky Fakri Izul. Fakri? Okay. What would be your choice or priority? Yeah? Why?
Tak tinggi sangat sampai consider diabetes, tapi yang memang tahu ada masalah iskemik.
Okay. All of your answer are wrong.
Oh.
Okay. So when patient present to us with those at risk of diabetes, pre-diabetes, managing the risk factor, which is the important risk factor to cause diabetes is why weight? Why body weight? Why body weight? Yeah? Especially weight at the abdominal area, as we mentioned just now. They lead to insulin resistant. And I'm sure you have learned about pathophysiology of type 2 diabetes. What are the pathophysiology of type 2 diabetes?
Not yet.
Shazwani Maisara.
Tadi.
Mana? Oh, again. I love you so much then. Vinisha. Alright, what are the pathophysiology of type 2?
ChatGPT. Kita tak belajar lagi.
DU2
Tak.
and okay, good. Why insulin resistant? Christina. Oh, Christina apa pula? Christina
Alamak.
Syamsuddin. Ada berapa Christina? Dua. Why insulin resistant?
Beta cell
Tak
dysfunction.
sempat Google cakap.
Beta cell dysfunction.
Mana Christina ni?
Cell
Oh, yang
dysfunction.
tu. Okay.
Beta cell dysfunction.
Oh, dia create another topic. Why beta cell dysfunction? Okay, next to you.
Allah.
Siapa? What is your name?
Diana.
Diana. Okay. Any thought of why beta cell dysfunction then? Because of the body fat. When we have excessive fat accumulation, especially at the abdominal area, that's caused insulin resistant. And insulin resistant is the main key that will lead to type 2 diabetes. Have you learned about signs and symptoms of insulin resistant? Have you ever heard about acanthosis nigricans?
No.
Okay.
Nigricans.
Ni,
Oh.
ini, yeah, all of this. This is a sign when patients start having insulin resistance. Have you seen this? You can
Yes.
see this everywhere, right? So, how to remove this? Spa? Can we go to spa and remove this?
No.
Can we?
I don't think so.
Or come, Jean? Can we go to spa and remove this? So how can we remove this? Yes, reduce weight. So wherever you have a patient come to see you with the term at risk, with the term history, past history of gout, for example. So you are managing the risk because obesity is also can cause osteoarthritis because too much weight. They can also cause gouty that we will talk a little bit later. Yeah. So managing weight is our priority. Is that clear to all of you?
Yes.
But when patient diagnosed with diabetes, that's a different problem. That's a different strategy. When patient diagnosed with hypertension, then that's different MNT strategies. When patient present at risk, then weight is our priority. Does that sound clear to everyone? Okay, so why? Why I say so? Because I'm referring to CPG of diabetes. Yeah? Where they say for prevention of type 2 diabetes, for prevention of type 2 diabetes, we have to achieve weight loss at least 7 to 10% of initial body weight within 6 months. So this is the priority. Level 1. Maknanya grade A evidence. What does it mean by level 1 grade A evidence? Which means when you read this from CPG, you have to do. If you do it correctly, you will get that intended clinical outcome. For prevention of diabetes. Okay? and you can read the whole thing. Because if you talk about diet, diet can only come at level 2, grade B. So what else? Grade A, reducing calories. So when we talk about weight loss, it must relate with calories. Because you have to reduce the intake. No matter it comes from fat, carbohydrate or protein, at the end of the day, it's a combination of all these 3 macronutrients. Have you learned about macronutrients? Yes. Macronutrients are carbohydrate, protein and fat. The combination will give calories. So as long as you wanted to manage weight, so the nutrient involved is calories. Not carbohydrate, not protein, not fat. You get my message clear? Yes. Okay, that's important. Yeah. So at risk, pre-diabetes, at risk of hypertension, history of X, priority should be put to manage the risk factor. And usually in this case, obesity. So when we talk obesity, you have to reduce the calories. Now, what other thing MNT can help? So I hope you are very clear that in managing nutrition and related chronic disease like obesity, diabetes, NCDs, non-communicable chronic disease, the basis of management is lifestyle. So when patient fail or when patient unable to cope with lifestyle, this is where pharmacotherapy will take place. Then only for those who have metabolic obesity, obesity with other chronic disease that cannot be controlled, we propose surgery, bariatric surgery. Okay, right. But no matter what kind of treatment patient is at, because I'm running metabolic obesity clinic, which I will talk a little bit more later, medical nutrition therapy is important across all these 3 categories. What does it mean? So no matter whether patient has successfully losing weight after bariatric surgery, they still need to adhere to medical nutrition therapy. That's what it means. Although patient on the high dose of medication for weight loss, which I will show you several, medical nutrition therapy is still important so that they can lose further more weight. Right? So that's what it means. So these are the benefits of weight loss. So how much we need? At least 5 to 10% for any chronic disease. Yeah, for the pre-diabetes just now, at least 7%. Then you can see the meaningful effect. Not just 1 kilo, not just 2 kilo. We have to calculate the percent weight loss. How to calculate? If we talk about 10%, patient present to you with 100 kilo. So how much weight loss we expected? 10 kilo. Is that easy? No. Good that you know that it's not easy. Yeah. Okay. So this is the review that I used to give some insight about MNT and also referring to CPG. So when it comes into obesity management, you need multi-component intervention. At least we need to give 3 strategies straight away. Reduce calorie diet, exercise and behavioral management. So I'm focusing on MNT where we have to give reduced calorie diet. And the best if we can use technology. So because patients go back, they can only see us after 6 months. So we need technology to support. What kind of technology? Can you give me an example? Tan Yi Jin? Yes. What are the technology in mind?
Application, diet application, counting the food calories, intake, glucagon.
Say again? Gym fitness equipment is technology? That's equipment. Tivia Darshini? Tivia? Yeah. Yeah, calorie tracking apps. Do you have an example? Okay, that's one of the example. That's one of the kaidah. strategies. Huzaifa? Yes, Huzaifa. What else? What other technology you can use and ask your patient? Chat GPT. Yeah, that's technology. Okay? Yeah, Huzaifa? The one that you wear right now. How many of you wear wearable, smart watch? Anyone? Ada tu, nampak. Alright? Terus suruh. So that's also one of the technology that you can use and ask your patient to wear. So they are more alert. Okay. Right. Okay, so no matter what type of diet, yeah, at the end of the day, have you ever heard about intermittent fasting?
Yes.
Atkins? Have you tried it before? Shake and everything? Bet me your patient has done that all. Yeah? But above all, this is all the tools to help them to reduce their calories. So when they reduce their calories, they can experience weight loss. So this is the way that you can start to calculate yourself the calories intake. So how much you need in a day. So this is a quick method that we use in the clinic. So for the patient who wanted to lose weight, the empirical formula that we use is 20 to 25 cal per each body weight. So for those who have normal BMI, less than 23, you can use 30. So you can calculate yourself. 30 times your current weight. So that's your energy intake requirement. For those BMI less than 18.9, you can use 35. Alright, so that you can have a bit more weight. So for those BMI between 18 to 23, you use the empirical formula 30. For those BMI more than 23, you can use 20 to 25 to current body weight. So let's see for Puan Rizky. Her current weight is 80. So 20 to 25, she will lose weight about 16 to 2000 calorie a day. That will help her to lose weight. But if she needs more weight loss, what I will do, I will minus 500 from the intake, from the required energy. So about 1100 to 1500. Okay? Right? And this is how 1500 calorie looks like. So if you give 1005, yeah, then this is how it looks like.
This is how the 1,500 that I mentioned is 1,500 calories weight loss diet for each. Yeah. So
Okay. Now let's discuss. Yeah? So this is another case. One risky. So at risk of diabetes with impaired glucose tolerance, what should you do now? Glucose or weight? Weight. Impact, yeah? At risk. So when patient present to you with impact, managing the risk, weight, so what should you reduce? Carbohydrate, protein, fat, calories, fiber, calories. Alright. Okay, so this is the clinic that we are talking about. It's not only a dietitian on board. We have surgeon, our surgeon, Ms. Zubaida, yeah, nurses, nurse manager, rehab physician, our rehab specialist doctor, Dr. Tana, endocrinologist on board, Dr. Fizal, Dr. We have clinical psychologists. So you imagine this gentleman has to meet all of these specialty during the clinic. Yeah, so our clinic is every Tuesday. So you may come across and visited us perhaps when you do your rounds later on, your clinical year. Yeah? So what does it mean by metabolic obesity? It's not only BMI more than 35 or 40, but they are also present with obesity-associated comorbidities. In my clinic, yeah, you can see our patient is this size. Their weight is usually more than 100. Their BMI is more than 40. So I hope when you see this kind of case, please do not call them. Please behave with your language. Don't say obese patient. Professor, I want to discuss this obese patient. Please do not label them. What are the best word to use? Yeah? Apa? Patient apa? Low in pain? Okay. The?
Sampai panggil apa? Patient.
No. Sometimes you discuss a case, Mr. Ahmad. Mr. Ahmad kat depan tu. So? Mr. A. Lagi dia marah. Nur Azwa.
Oh,
Ada berapa Azwa? Okay. Yes, Azwa? Patient with this BMI. But what is the best term to use? To refer Theophilus. Mana Theophilus? Yeah. Not so much specific. Okay, usually that's good try, but the term that we have to use when we wanted to say about obesity is people living with obesity.
Oh.
Living with. Yeah? Because we don't want to label. And indeed, you cannot call patient as diabetic patient anymore.
People living with diabetes.
Patient living with diabetes. PLWD,
Patient living with
PLWO. Yeah, so that's, be careful on the language. Because if you start saying, ni lah obese patient ni. Or when you measure their weight is 150 and you start putting your startnya, they won't come back to your clinic. So be careful on how we react in front of our patient. BMI 50. Yeah. So BMI 50 is nothing now. It's common now.
It's common.
Yeah. And majority of my patient, when they come, their weight is BMI more than, their weight is triple digit. Yeah, 100 plus. 100, I have patient with 180. Tu wah. Be careful on that. Wow. Right? And in our clinic, our chair is like 3 kali ganda ni.
Oh.
Okay? To accommodate their needs to sit. Because they cannot sit like this. So my wish to all of you, if you come across this clinic, this chair, please don't share the chair. Don't sit on that chair. Because why? When patients see 3 orang boleh duduk, aku duduk seorang pun tak muat, how do they feel? Okay, so I'm not allowing my student to sit on that chair. That chair is privilege for them. We want to welcome them to come to our clinic.
Yeah.
Right, so don't ever sit there. That's for your patient. Because when you sit there, you sit 3 of you, your patient see, besarnya I. Kan? Right, so that's perspective. And all my patients come with at least 2.5 comorbidities. What does it mean? They can come with sleep apnea, they come with diabetes, they come with fatty liver. So managing obesity is complex. And these are the medication that we use, yeah, for them to jab daily. It's not insulin. It's called GLP, the generic name is GLP-1RA, yeah, GLP-RA, and they have to inject every day so that they can control the appetite. Yeah, and these are, you know how much is it cost? For 1 month in our hospital, it costs our patient at least 1,500 ringgit.
Oh.
But in other clinic, they can cost up to 3,000 a month. Now it's being sold. If you go TikToks, they have a lot of celebrities that use this because it's truly amazing drug. Yeah, for weight loss, but it's not subsidized. So a lot of my patients are not able to buy. Okay, we are talking about 200 kilo patient. Diet alone doesn't work, because they will be pretty hungry. Okay, because you wanted to reduce calorie, right? So when you reduce calorie, you need help from the drugs that help them to control their appetite, help them to get rid all the hunger pain. Okay? Alright, so this is also another drug that just introduced last week. our hospital is called I don't know what is the name for generic, maybe this one. Yeah, but the brand name is Contrave. So how does it work? It helps patients still to control craving and hunger. Yeah, so they off. This is the same drug that help patient to reduce the need of smoking. So they control that particular side so that patient don't feel the needs of eating. But they come with various side effects. One of them is vomiting, nausea. It's terrible. Yeah, some patients. So that's where the dietary strategies is important. We know how to treat nausea associated with this kind of medication. There are tips and strategies. Okay, so now let's focus. We handle with obesity. Now let's focus how to manage other comorbidities. The same patient, we just focus on the right, the yellow highlighted. At risk of hypertension, BP slightly elevated, not on any medication. What should you do now? Protein, sodium, potassium, calories? At risk.
Sodium.
Calories. Weight loss. Okay, although sodium is important, focusing on weight by reducing the calories will do better for the patient. Okay? So obesity, and reduce and manage the energy intake and calories intake, because we can see, for example, for hypertension, ada tak kat dalam ni? Ada lah pula. Yeah, at least with a drop of 10%, they can normalize their blood pressure, because getting slimmer, reduce the weight, the pressure of the moving of the blood are become lesser. Yeah, okay. So patient have hypertension together with morbid obesity. BP is high and on antihypertensive drug. What should you do? Now they already have hypertension. Yeah, this is where you have to modify the sodium intake, increase the potassium. Potassium come from fruits, vegetable. Yeah, okay. So when they already have a diagnosis, then MNT will be specific to that particular diseases. Yeah. So those at risk, we want to prevent them to get the disease. So what we need to achieve significant weight loss, 5 to 10%. And when we talk about weight loss, we talk about reducing the energy or calories. These two terms are similar. Okay. But when they already have a disease, then we need to manage the disease and prevent them from complication associated with disease. Hypertension can cause stroke. So we need to manage the blood pressure by giving low sodium diet. Makanan rendah sodium. Contohnya garam. Contohnya McDonald's, fast food. Alright? Okay, good. So this is the focus, improve disease condition, but long term, we should target weight, but not that during the first visit immediately. Okay? Alright, so these are the MNT strategies on obesity with chronic disease. So if we talk about patients who already diagnosed with diabetes, so the management will talk about carbohydrate. We modify carb, we modify sugars. Okay? How about NAFL, non-alcoholic fatty liver, and sleep apnea? Because we don't have any specific diet to give you sleep, but only weight loss will help. Yeah. Dyslipidemia, patient come to see us with hypercholesterolemia, high LDL, give them cardioprotective nutrition. So these are the example of the food. So hypertension, reduce sodium, need already at a disease state. Yeah? And there are one dietary pattern that you may heard a lot called DASH diet, dietary to reduce hypertension, dietary strategies to reduce hypertension, introduced by American. Yeah, we use that as well in our clinic. How about gout? Already have gout and still have gout. So during that particular attack, you have to give low purine diet. What is low purine diet come from? Seafood, food that can increase the purine as one of the metabolite after eating. Yeah, seafood, anchovies, internal organ, these are the example. But when patient has a history of gout and obesity, then we manage the risk of obesity by reducing weight. Okay, right. And for those who have gout, we also need to talk about fluid because we have to flush out. Yeah, they have to drink a lot, and they also need to take fiber. How about patient with impaired kidney? Impaired kidney is not at risk, it's already a disease. Yeah, like CKD stage 3, 4, 5. Yeah, when you learn them later, then we give sufficient protein intake. We don't want to give higher protein. Higher protein will exaggerate kidney failure. Right. So that's one of the strategies. Okay, patient had history of gout, no more attack. This patient, obesity, what should we do? Reduce calories intake. Okay. Now let's meet our patient. Yeah. Let's meet our patient. He has morbid obesity. Let's discuss the case. BMI 40 with 4 comorbid conditions. Type 2 diabetes, polycontrol, dyslipidemia, hypertension, OSA. What is OSA? Yes. And then NAFL? Yes. So they have all of these conditions. 1, 2, 3. In fact, 5 comorbid conditions. What should you do now? Can I do weight loss? What should be my focus for diabetes? Carbs management. Yeah. Dyslipidemia, we need to talk about fat. Hypertension, sodium. OSA and NAFL is weight loss. But since weight loss will take longer time, and as you mentioned, glucose will have acute changes, managing the carbs will be better. Alright? Okay. So that's all. These are my summary. Any question? And what I would like to suggest, not suggest, recommend, work as a team with dietitian. We appreciate referral when you have a cases so that we can manage the case together. Alright? With that, thank you very much. Any question you can ask. Thank you.
Thank you, Doctor.